Hi, my name is Mary Beth Utley.
And I'm Tasha Copeman. We are second year health information technology students completing a research project on the impact of COVID 19 on the HIT professionals. As we know, on March 11th, 2020, the World Health Organization declared COVID 19 a pandemic. We know that COVID has impacted the healthcare world in many aspects, including changes in work roles and locations, everyday challenges, coding updates, and reimbursement. We hope this presentation finds you healthy and safe, and we thank you for watching.
The first thing we are going to talk about are the new roles in the HIT world due to the COVID pandemic. Some HIT professionals changed over to registry designers. They were responsible for creating a registry to help address knowledge gaps, track the virus spread over time and across geography. The registry also worked to measure economic and health impacts and anticipate healthcare needs as the pandemic progressed. This is also used to identify popular and effective sources of information. A second role includes being contact tracers, as it helps slow the spread of COVID-19 in order to protect you, your family, and your community. Contact tracers contacted those who were in close proximity with an infected person for a total of 15 minutes or more that have had a confirmed or probable COVID-19 diagnosis and recommended testing. Next, HIT professionals turned into frontline workers. This may include posting visual alerts in strategic places in the facility about infection control and hand hygiene. They were also responsible for providing masks and hand sanitizers and limiting and monitoring points of entry for the facility. They also assisted in mobile testing and triage. Screeners were responsible for completing temperature checks and screening questions regarding symptoms and potential exposure. Due to the pandemic and limited in-person exposure, HIT professionals helped design and implement telehealth services to continue with a healthy workforce. This would help medical professionals continue with their treatments face-to-face through using video conferencing. They had an increased responsibility to assist in designing data capture for a telehealth appointment and to audit the integrity of the record in order to maintain compliance, finance, and reporting requirements.
So let's take a survey. I want you to think back to when COVID first started and answer these following questions. The first question, did your operations remain business as usual? Did your operations remain business as usual but with reduced staff? If your business operations changed, did your job functions transition to a remote or a virtual setting? If your business operations changed, did staff complete other functions as described on the previous slide, such as registration or screening? And finally, if your business operations changed, were you asked to help with privacy management, data analysis, tracking, coding, or other areas not previously described within your scope of practice? So AHIMA conducted this survey with these questions in the regions of America, East Mediterranean, and the Western Pacific about 4 months after COVID began. So they found that in the regions of America, 57.69% said most of their job duties changed to being conducted remotely, while only 23% said business remained as usual. In Europe, 100% of the staff reported helping with privacy management, data analysis, tracking, coding, and the other areas not previously described within their scope of practice. And then in the Mediterranean, 33% reported business as usual, 33% reported other functions, and 33% reported helping with areas not previously described within their scope.
Now we will talk about the challenges healthcare has faced during this pandemic. COVID-19 has changed the work culture in the way we operate across the health information technology realm. The first challenge is being able to manage privacy of data while addressing public data. Non-designated people, such as researchers, wanted access to patient data for reporting as there was so much information that is unknown. This created a burden to ensure appropriate data capture and the timely and accurate reporting of facts to support decision making. For example, facilities still need to comply with HIPAA regulations to protect their patients and employees. If an employee tested positive, the facility is unable to disclose the name of the individual. However, the facility needs to notify other individuals who had had contact with this employee. Next, we'll talk about the use of technology. The use of technology also posed an additional challenge. If a facility had an EHR, working offsite was a smooth transition. However, for the facilities that did not have an EHR, they had to keep employees in the office. They had to address how they would maintain social distancing, sanitation, and infection control. With the lack of technology, the handling of paper records added additional stress and increased exposure risk as there was lack of information on how to handle paper records properly. There was also a challenge with working remotely as employees had to move their office to their own homes and designate proper and functional workspaces. This poses an additional challenge with clear and consistent communication, which is more important than ever. All employees need to be kept informed in preparation for changes in order to continue to complete their job duties effectively. In person, this could have been done as in a team meeting. However, now employees need to rely on emails, phone calls, chat features, and video conferences to communicate with each other. Additionally, being a new employee led to more challenges as they lack experience and have not fully developed their skill set. This creates additional stress as they don't have in-person contact to address their questions readily and promote confidence. They may also be the first to be laid off due to the need to cut expenses.
All right, let's talk about some new codes. So as of January 1st of this year, these new codes went into effect that we have displayed on the slide. Learning these new codes and the regulation as well as the sequencing rules is important so we can code medical records correctly for reimbursement. We still need to be diligent in auditing and monitoring documentation to support these codes. So when we use the U07.1 code, it should be sequenced first, followed by the appropriate codes for the associated manifestations when COVID-19 meets the definition of a principal or first listed diagnosis. The exception would be when another guideline requires that certain codes be sequenced first in the case of obstetrics, sepsis, or transplant complications. And we know if COVID-19 does not meet the definition of the principal or first listed diagnosis, for example, if it developed after an admission, then the U07.1 should be used as a secondary diagnosis instead. In the instance of CPT codes, the two new vaccines are differentiated by the dosage and if they were diluent reconstituted. The administration codes are differentiated by the dosage amount administered as well as the number of injections given in the required scheduled series of 2. We included some coding examples that we can go over. The first example, Mr. Jones was an inpatient and tested for COVID, and the test came back negative, but he tested positive for pneumonia and the flu. Should we be using the Z code in addition to the diagnosis of flu and pneumonia? We definitely want to assign the codes for flu and pneumonia, followed by the Z20.828 code. Example 2, Susan was admitted for a liver transplant rejection, and 10 days into the admission, she develops new onset cough, runny nose, and tests positive for coronavirus. Documentation shows COVID-19 with very mild symptoms. How is this sequenced? Our principal diagnosis would be P86.41 for the liver transplant rejection, followed by the COVID-19 diagnosis for our secondary. And our final example is a patient is admitted with pneumonia due to COVID-19, which then progresses to viral sepsis. So how do we report this? We use the U07.1 diagnosis for COVID as the principal diagnosis, followed by the 841.89 for other specified sepsis, and J12.89 for other viral pneumonia as our secondary diagnoses.
We are now going to discuss revenue. Hospitals and healthcare systems were estimated to lose $323 billion in 2020. This is in large due to the increased cost for additional PPE, that healthcare providers needed to wear to keep themselves and their patients safe. The common PPE items that were worn were masks, gowns, gloves, and shields. And the non-PPE items that we were spending more money on were oxygen tubing, increased laundry and housekeeping services to sanitize and keep everything clean to reduce the amount of exposure. Money was also needed to be spent to expand capacity due to the increased volume of people admitted and needing a place for treatment. Additional wages were also an issue, as some healthcare professionals worked overtime to cover shifts of those employees who tested positive for COVID-19 or were exposed to COVID-19. And other healthcare professionals traveled to hotspots and other facilities to meet the needs. There was a significant decline in revenue due to eliminating elective and non-emergent procedures, which accounts for approximately 50% of revenue. There's a decrease for treatment of diseases that are not related to COVID. For example, many individuals put off going to their routine screenings and avoided treatment for minor health conditions such as earache and sore throats. Tasha and I both work in long-term care facilities as therapists throughout the pandemic. One of the first changes that we noticed and started to eliminate during the pandemic was we eliminated visitors and we were constantly wearing masks. We experienced a PPE shortage and were unable to keep enough gowns in stock. At one time during the beginning of the pandemic, we were wearing plastic rain ponchos that we had to sanitize and rewear every day and change out for every patient. We then changed to washable gowns, but the laundry had a difficult time keeping up with that. We finally were able to get enough disposable gowns that we are still currently wearing. Looking at the revenue aspect, gowns used to cost cents, and then they increased to $11 a gown. I worked in a COVID positive building, and we actually had to outsource our gowns and masks to be sanitized at the hospital to be reworn. We also had an increase in the use of oxygen tubing, as most elderly patients, once they contracted COVID, they needed the supplemental oxygen to help fight the disease. We will be making up for the lost revenue from 2020 for years to come.
So this has been a really challenging time for all of us, and it's important to take time for ourselves. So we just wanted to include this short video on some tips on how to do that. As you know, COVID has impacted all of us, but we have been able to adapt to all these changes as they have come. We have had changes in our job roles. We've gone to working remotely and learning our new codes with the sequencing rules. The use of technology has allowed us to continue to do our jobs throughout the last year, which I'm grateful for. We wanted to thank you for listening to our presentation, and we've included our references on this last slide. If you have any questions, please reach out to us or our instructors, and have a great day.